Hello everyone, my name is Dr. Aldo Leopardi and it is my pleasure to present this webinar on Complete Denture Therapy to Fundamentals Part 1. Before I begin, I'd like to thank the sponsors for this webinar, and they include Horaeus Dental and the Knowledge Factory, and I'll reintroduce the sponsors at the end of the presentation. Complete dentures. Why bother? It begs the question, considering that people are keeping their teeth longer, why bother becoming proficient at complete dentures? Well, I want to take you all through some statistics here in the United States of America. Essentially, the elderly, they make up the largest growing segment of American society. Now, although aging is not a cause of tooth loss, the incidence does increase with age. And it's predicted that there will be approximately 38 million dentureless elderly adults by the year 2020, especially when compared with only 33 million in 1991. So when you put this all in perspective, considering the overall number of completely edentulous individuals is expected to increase over the years, removable pros will continue to be a necessary treatment modality in clinical dentistry. Now, there are many reasons for tooth loss. Obviously, age is not one, but the incidence does increase with age. For instance, people lose their teeth for a lot of reasons. Well, Suzanne, she was in her early 50s. She lost her teeth as a result of significant periodontal disease. Suzanne became a very good complete denture patient. Harold, disease as well, a combination of perio, but primarily caries and neglect. And he became a good denture patient also. Linda had some medical problems, so she had a significant medical history of lupus and a bunch of other problems, and with neglect, periodontal disease and caries, she lost her teeth too, became a good complete denture patient of her moral also. Well, they're one of the reasons. Probably one of the most important reasons today for becoming proficient in complete denture therapy is this, and the fact that complete denture therapy is the gateway to implant overdenture therapy. With implant therapy becoming such a significant part of clinical dentistry right now, and a growing segment of clinical dentistry, and patients demanding better treatment options for their partial or completely edentulous conditions, complete denture therapy will allow the clinician to be able to treat the completely edentulous patients with dental implants. Without a thorough base, a thorough knowledge of complete dentures, you really cannot treat patients with implant dentistry that are completely edentulous effectively. So that alone is a wonderful reason to learn about complete dentures. This is a perfect example of my patient's normal Jean, who presented with an old existing upper denture and some remaining lower teeth. And the lower teeth were non-restored, but it needed to come out. So the treatment for her was complete denture therapy, a new denture in the upper, and also an immediate denture in the lower. And utilising these Horaeus teeth, these mondial teeth, we got a really good result. But after a period of time, she realised that her lower complete denture wasn't providing the satisfaction that she wanted. She wanted something more stable. She wanted quality of life. And we were able to provide that through implant therapy. And using the immediate denture as a guide, fabricating a surgical guide, a guided guide. Oral surgeon placed dental implants. I placed transmucosal abutments, took a splintered open tray impression, and then went back to complete denture technique and utilising a master cast, fabricating a wax occlusion wax room, which we're going to discuss today, taking an intraocclusal record, maxillomandibular relations at the correct vertical dimension and horizontal CR record, and using complete denture technique, taking it to a wax try-in or before making the bar. And the bar is made only after the wax try is tried in the mouth and verified. And this is a mill bar, so utilising CAD/CAM technology, even some modern technology for the bar fabrication, titanium in fact, and then trying those titanium frameworks in the mouth. And this titanium framework was designed to have convex surfaces on the entirety of the surface, so that the patient, normal Jean, can clean it effectively with floss, bristle brushes, and clean her teeth with a toothbrush. And the separate bar trying verified a passive fit absolutely beautifully. And then putting teeth back on, transferring those teeth from the wax trial denture onto the bar and verifying occlusion, verifying vertical dimensions, CR, verifying aesthetics and phonetics before processing the hybrid and delivering it to the patient. So this happens to be a screw retained, acrylic fused to metal, actually acrylic fused to titanium, hybrid prosthetic, implant supported, implant retained, and a beautiful treatment result. So what we end up here with this patient, on Gene, a new prosthetic utilising the raised teeth and the new prosthetic that I made originally, the maxillary denture, the same one that I made originally against the mandibular implant over denture. I think you can appreciate that without a thorough knowledge of complete dentures, we would not be able to provide such a thorough treatment for this patient and a complete treatment. And bear in mind, this patient started off as a complete denture patient with a view toward possible implant therapy if she felt a need for implant therapy. And she wanted that. She wanted improved quality of life. She wanted something better for herself. And we'll talk a little bit about her later on. So this is before we started, and this is where she's at today, where she's at right now. Here's another example of Dolph. Dolph had periodontal disease and made him a complete denture. And he didn't like his complete denture. He liked everything about it except for the fact the palate was covered. So he was motivated to have implant dentistry, 4 implants, far over denture, metal reinforced over denture, stress broken design, but palateless, and he loves his prosthetic. Doyle was interesting. Doyle started off as a patient that was dissatisfied with his old dentures. And he came to me and he wasn't even wearing his bottom denture that was made a few years prior by another provider. I made a new set of dentures utilising raised teeth. These are the Mondial eye teeth, they're beautiful. And he perceived value in the process and decided to move forward with implant therapy. He decided he wanted something better, he wanted quality of life. He had 8 implants in the maxillary arch and 5 implants in the mandibular arch and had fixed prostheses, screw retained, completely implant supported, implant retained. And these prostheses are acrylic fused to metal prostheses. And he loves his teeth. Again, raised teeth, raised Mondial eye teeth. We'll discuss those teeth later on in the presentation during teeth selection. This is Doyle. Another example, Edith. Edith, same situation. Periodontal disease, I made her a complete denture. She wanted something better. She wanted to invest in herself. And we'll have a treatment plan using the complete denture that I made her as a duplicate, as a guide for implant placement. 8 implants were placed. And she went for the ultimate, which in her situation was porcelain. She went porcelain, fused the metal, a hybrid approach, screw retained, beautiful aesthetics. She wanted the ultimate, and she invested in herself. Again, none of this could be possible without a thorough understanding of the complete dental technique. And I think that's why it's so important nowadays for dentists to continue to learn about this treatment modality, not just because of the statistics, but because of what people are desiring, what they want. Okay, so that's the lead up to complete denture therapy. Let's discuss complete denture therapy. Essentially, these are the sequences, these are the appointments needed in order to provide consistent, predictable results for the completely dentulous patient. It starts off with a patient interview. And in my practice, you can imagine I'm in private practice here. I'm a prosthodontist. I practice in Denver, Colorado. Practice is limited to implant, fixed, and removable prosthodontics as well as cosmetics. The patient comes in and we have a look at their condition, we diagnose a treatment plan, and go over financials. And it's usually not to the next appointment that we can actually begin treatment. So appointment number 2, we take some initial impressions, pour those up, and then make custom trays. And for appointment number 3, we take secondary impressions. These happen to be border molded with polyvinyl siloxane and a wash with polyvinyl siloxane. So this is border molded with elastomeric impression material. And then the 4th appointment is a jaw relations appointment. This is where we take the maxillary mandibular jaw relations, the vertical to horizontal, and select the teeth as well, teeth selection. And appointment number 5 is the wax trial denture aesthetic trying appointment. Very important appointment to verify your vertical dimension, verify your centric relation, verify the aesthetics, tweak the position of the teeth, and get the patient approval before processing. And then appointment number 6, delivery appointment. And post-op adjustments, usually 2 or 3 after that. Now, of course, what you can do with all these appointments, you can combine a few of them, but essentially the principles need to be followed, no matter if you combine some of these appointments or not. The purpose is not to take shortcuts. The purpose is to be thorough and to be consistent in order to get those type of results that you've seen. Well, we have about another 50 minutes in the presentation, obviously, and it's impossible to discuss complete denture therapy in 50 to 60 minutes. What I'm going to focus on today are just a few different aspects in this particular part. And I'm going to focus on teeth selection. Also, how do you arrange those teeth to provide an aesthetic denture setup and an overall pleasing result? And how do the records, how does the maximum amount of your record appointment tie into all of this? Because they are all interrelated. Let's start here. Anterior teeth selection. Now, there are a lot of methods available for choosing anterior teeth, but the most important thing I want to share with you is that when we look at the literature, really there is nothing in the literature that is objective with this process. It's not an exact science. It's truly more subjective than it is objective. And I'm going to discuss some of the techniques that are reported in the literature to help you and I select an appropriate tooth, size, shape and shade for the patient. Even after we go through the process of selecting a tooth that you and I like, that we think will work for the patient, at the end of the day it's about the patient. And they have to accept this tooth, so we need to verify what the teeth look like in wax trial, denture appointment, and trial days. And have the patient confirm it, have their family and friends even make sure they like it too. Otherwise, once it's processed, we can't go back. Well, let's talk about shape. I recommend, as far as the technique for shade selection, is you pick the shade. You pick two shades, that's it. Just select two shades that you think is going to work the best for the patient. Obviously ask the patient what they want. Do they want a more youthful looking smile? Do they want a more natural looking smile? Do they want white teeth? Well, most people don't want dark teeth. Most of the time they don't. They're going to want something that resembles the shade of teeth in this society. And in America, we are a pretty bleach orientated society. We want white teeth. And what I look for, I select the teeth. I usually don't go into the bleach shades unless it's requested by the patient. I try to stay out of the bleach shades. I would go for like an A1, A2, sometimes even an A3. And I look at the shades against the complexion of the skin, see how it looks, and the sclera of their eyes. And the reason I do that is if the teeth fit within the sclera of the eyes, it's not going to stand out too much. If the teeth are much whiter than the sclera of the eyes, then it's going to be pretty obvious. Much darker than the sclera of the eyes, it's also going to look not so hot also. And then once you've done that, you can have ask the patient which one of those two shades they like. Then you can engage the patient at that time and have the patient make a decision. Ultimately, it's their teeth. Ultimately, they're the ones that are going to wear them. So they're going to be happy with them. So just check with the patient, make sure you verify with the patient that which shade they want. Engage the patient. That's basically the technique I use. Now this is a pretty cool example about shade selection. This is Frank, and Frank's a retired gynecologist, and unfortunately for Frank, as you can see, he's got pretty dark teeth. He's got like A4, A4-5 teeth. And he's retired, neglected his teeth over the years, as you can see, and unfortunately his maxillary teeth need to be removed, and his lower left mandibular teeth need to be removed. The treatment plan for Frank was immediate after complete denture, and just maintain the lower premolar occlusion and stabilise his lower teeth. A couple of things about Frank. When I made him his immediate denture, and this was his first immediate denture, this is 9 months into his immediate denture therapy, he didn't want to change his look too much. He's very active within his society, even though he's retired in his field, and he didn't want his friends, his mates, to really notice that he had dentistry done. Well, I mentioned to Frank that I'm not going to reproduce his aberrant teeth. I don't want to reproduce those teeth. I want that flash. I want that good looking. I want to give him a good looking set of teeth, but also to fit with his personality. He loved his diastema, so I decided to keep his diastema, straighten his teeth out, but give him an A3 shade, something that is a little bit lighter, but not super white, not A2, not A1, just so he gets used to a more lighter, more clean looking tooth. And he loved it. He loved it. But he didn't love his complete denture. He went forward with implant therapy. In fact, complete denture therapy is often a good motivator for patients to move forward with something better, something that will work better in their lives. And Frank went forward with an implant fixed restoration, and it happened to be acrylic fused to metal hybrid restoration. And in this, we were able to close the diastesis completely now that he was used to a better looking setup, and also go to an A2. So by gradually having Frank accept an A3, and then he was able to accept an A2, we ended up with a really nice result for him, going from A4 to A45 to A2. And it looks fantastic. He really enjoys his new smile. Same shape teeth that he had before the teeth were extracted, they're just positioned correctly. 6 dental implants, cross-arch stabilized, screw-retained fixed restoration, acrylic fused to metal. So this is where Frank started with an A45, and this is where he is right now. So we went A45, A4 to A3 with his transitional complete denture, and then A3 to A2. And he's loves it. Well, that's shape. Let's talk about size and shape of teeth. Well, essentially, there are a couple of techniques for this. The best is when the patient has some pre-extraction records, whether they be diagnostic casts, even photographs are very useful, and radiographs to a less degree. I talked about Suzanne earlier. But Suzanne, I used her original teeth as a guide and just position it in a more favourable position, a more steady position for her. Now, with Howard, it was a little bit more challenging because there wasn't much to go by. His teeth completely deteriorated. But I was able to use some of his line angles, some of the mesial and distal walls of some of his teeth, just to give me a rough idea about the size and shape as well, and extrapolate. A bit of detective work and going backwards with those. Of course, with this patient, I was able to use her original teeth to give me an idea, a rough idea about size and shape. And then chose a Heraeus mold, which has a nodule eye, that I thought was pleasing, more feminine, more attractive for her, and it worked out great. So using those as a guide, the original teeth. Same here, Old Crown Bridge, and this lovely lady that needed to have these teeth removed. And this is a phase 1 denture, and these are a nodule eye teeth as well. Essentially, I like the overall shape of the teeth, and I found a nodule eye tooth that was very similar. It had rounded ends, and nice and soft translucency. Rearranged them in a better position, fixed the canter. As you can see, there was a canter in the smile, fixed that. And by using old teeth, they gave me a good idea of what I wanted as far as size and shape for her definitive denture teeth. Same thing with Doctor, I showed you earlier. He's got big teeth, a big fella, so I chose large teeth as well, but also chose teeth that are very, very aesthetic, very dominant, and we'll discuss those in greater detail in just a moment. Size and shape. Now, sometimes you don't have post-extraction records, and you've got nothing to go by. You don't have photographs, you don't have anything, except for maybe an old denture that was made before. And for this lady, an old denture is what I used as a guide. I thought the dentist chose the teeth wisely. The shape was great. The only thing I wanted to change was shade, and so did Jackie in this case. She wanted brighter teeth. Also, though, I wanted a little bit larger, so I chose a similar mould, similar size and shape, actually similar shape, but I chose a larger tooth, and it worked out great for Jackie. It's before and after. Ted had an old denture at the top, a couple of non-restorable teeth, and a partial denture down the bottom. His treatment plan was a new upper denture and lower implant therapy. It actually wasn't 2 implants, but a bar over denture. I was able to use his old teeth, though, to give me an idea about width. And then he wore them down too much, but I like the width. I like the width of the central incisors. So I was able to use that as a guide. And then I chose a shape that I thought was appropriate within the width parameters of his old dentures. So even his old dentures were useful to help me at least work out width. And then I was able to determine the rest from the techniques we're going to discuss in just a moment. Now, with Norma Jean, a little bit about her, I thought the width of her teeth were pretty good. They weren't too bad. She wore down her old denture, as you can see on the left, and the shape, not too shabby, not too great, but I use these guidelines for the size of her teeth, as far as that goes. Now, for Bonnie, her chief complaint was aesthetics. She didn't like the way her teeth looked. And she was a complete denture patient, and she still is. And I'm very satisfied with that. She doesn't even want dental implants. To be honest with you, she's actually afraid of surgery, so she's got a phobia that she's dealing with right now. But she's a good denture patient. As you can see with her complaint was that she didn't like basically just the size of the teeth and the arrangement of the teeth. She just didn't like her teeth. So we chose to raise teeth that are a little bit larger, a little bit more bolder, and arrange the teeth in a more aesthetic pleasing manner. You're going to see her later on in the presentation. Cool, let's continue. And this is Bonnie now. So this is Bonnie, and a much better result. So let's talk a little bit more about size and shape and what techniques we can use. Let's say your patient has nothing to go by, nothing to help you. These are some of the theories that have been reported in the literature to help us with tooth selection. And starts here with the type of form theory, which is basically matching teeth face form. First proposed by Williams in 1914. You're going to notice that with manufacturers, this is what they do. They break down their teeth into different shapes, either square type teeth, ovoid teeth, or triangular shaped trapezoidal teeth, or combination of these different areas. And although there is no scientific evidence to support the type of form theory, is absolutely none, it's actually a good place to start. And it helps manufacturers organise their teeth in a manner that allows us, the clinician, to be able to go to the mould guide, either a mould chart or a working mould guide, and help us start somewhere to select the tooth that works for that patient. So it's a good starting point for us. And this is essentially the theory. You know, a person that has pretty square, bold features, you choose a square tooth. Person has got these rounded features, an ovoid tooth, and of course trapezoidal features, trapezoid tooth, triangle tooth. Then there's a theory of dentogenics. Now this theory was proposed in the 1950s, and what this theory does, it takes the patient's gender and their personality and age into consideration. Again, it's a theory, no scientific basis here. It's actually quite useful. And this is the theory. You consider teeth that have rounded corners and delicate appearance as more feminine, and those teeth that have prominent, for instance, prominent wider centrals, squarer edges, even some incisal embrasure or worn cuspis, they indicate aging, and also they project strength and vigour, a more male or a more dominant feature to the teeth. Now, I have a couple of problems with this theory, and the main one is the incisal abrasion, worn cusp tips. Yeah, to a certain degree it's a good idea to do that sometimes, but patients don't want worn down teeth, and they don't want discoloured teeth, which indicates age as well. So we use this as a guide, but maybe not to its fullest extent. Patients do want a more youthful appearance, but also realistic as well. So it's also another theory. Dentogenics is another useful theory. Okay, let's apply these theories to Lou. Lou's got interesting features. He's got ovoid face, but he's also got a square jaw. So he's got a combination of ovoid and square features. Here's a tooth mold on the left for Lou. It's got rounded ends. Tapered, rounded ends. Combination of taper and rounded ends. It's a softer look. Well, I chose another tapered tooth, but this tapered tooth has squarer incisal ends. So when we compare the two, you can see the differences now. I think that the mould that's got the squarer incisal edges is a more pleasing looking tooth on Lou compared to the one that has the rounded ends. So this is using the dentogenics theory. Now, I brought Lou's pictures up earlier. Out of A1 and A2, they both look good. Believe it or not, A1 looks great, doesn't it? A1 suits the complexion of his skin. It matches the sclera of his eyes. A bit bloodshot in these photos. But nonetheless, they still match the complexion of his eyes. And we chose A1. Actually, Lou chose A1 and I like them. And this is the setup we used. This happens to be a raised tooth. Happens to be a Mondial range. Tapered with square ends, and it looks amazing. It looks really, really amazing on Lou. But what I did for Lou, I did something else. I tried another denture tooth just to compare. So this is Lou. On the left you see Lou that has tapered tooth, but with rounded corners. especially those distal corners on those teeth, much more rounded compared to the mondial teeth that I eventually chose for Lou. And of course, this is a personal preference, but for Lou, I think squarer tooth, bolder looking tooth, now this is dentogenics, the theory of dentogenics, looks better than a tooth that actually has rounded ends and is more feminine in appearance. And it's interesting, the theory is useful, we use it as a guide, and so using the typiform theory and dentogenics theory as a guide to help us select teeth. And Lou just has some old dentures that were terrible old dentures, bloody awful, and couldn't really use those as a guide. So we had to use these concepts that had been introduced in the prosthodontic literature to us to help me and Lou select an appropriate tooth for him. Another example, and I showed you this patient earlier, this is Dolph. And look at the size, look at his teeth, they're large, they're completely square, not much in the way of rounded ends, only a little bit. Very dominant looking tooth. Perfect for Doyle. He's got really square features. Good looking fella, he's in his 50s, square features. He works in construction, he owns a business actually. He refurnishes basements. And he's got a lot of crew around him. This looks amazing. Square tooth dentogenics. So this is how that theory works. I showed you Norma Jean before. Now Norma Jean's interesting because in her past life, before she retired, she was an executive in marketing. Pretty high roller and travelled all over the world, very dominant personality. I wanted a tooth that showed off her feminine side, but gave her some dominance as well to reflect her type 1 personality. It's a larger tooth, some square features and delicate rounded features too, just to balance it out. This happens to be a Horaeus mondial range, and turned out great for her. So there's Norma Jean. Lorraine's interesting. She's got a rounded face, and I wanted those delicate features. Lorraine's a retired woman. She's a grandmother. She's in her 70s, and this is a makeover for her. This changed her life. She had an upper denture that I made for her and a lower implant retained denture, 2 implants with 4 abutments, and she loves her teeth. Now these happens to be long teeth. She's got a high smile line, so I didn't want to display much in the way of gum tissue. I wanted to display primarily teeth, so because of the high smile line. So these are long teeth, but they're delicate. They're tapered with a lot of rounded, delicate features. And these are the mondial eye teeth. They have a translucency built into them. So the mondial teeth have less of a translucent sizable edge than the mondial eye teeth. And these mondial eye teeth project a youthful appearance with the translucency. They have more mamelon type features going on. With these teeth, they're beautiful. They are more youthful looking teeth. They're great, amazing in that respect. And this is Lorraine. So this too fits her face. It is slightly tapered, ovoid, very rounded, delicate features as well. And the sizable edges translucent. These are the mondial eye teeth. And interesting enough, when we look at this patient, this is her old dentures before. She needed to have a new upper denture and a lower immediate because those lower anterior teeth were non-restored when you come out. I chose the same tooth I chose for Lorraine, the same one that you saw before. So if we go back, these are Lorraine's mondial eye. I choose exactly the same mold. Just rearrange the teeth differently to suit her aesthetics, arrange the teeth differently to accommodate her mouth and her anatomy. And they look different in her mouth as they do in Lorraine, but they're still gorgeous, still beautiful. These are mondial eyes with the incisal translucency. They look great, they fit her face. As you can see with her, she's also got sort of oval features, rounded features as well. Okay, let's go to some more guidelines. When the patient doesn't have much to give you as far as pre-extraction records or anything of that nature, a couple of things you can do with a jaw relations appointment and a wax rim. Let the patient smile, not excessively, and mark the corners of the mouth on a wax rim. And then with a plastic ruler over a rounded curvature of that wax rim, measure the distance between those marks. Gives you an approximate width of the 6 anterior maxillary teeth. Just a guide to help you select what size teeth to use for a patient. Now, as a general rule, when the manufacturers make teeth for us, we consider teeth that from the distal 6 through distal 11, canine to canine, If it's less than 48 millimeters, these are relatively small teeth. Anything larger, over 52 millimeters, is considered relatively large. And of course, in the middle is a medium. So these are some of the guidelines we use. A couple other guidelines, and this is more of a guideline after you select the teeth and you arrange the teeth on the wax rim. When you evaluate aesthetics, if you find that the cusp tips on a curve, when arranging the wax rim, if it pretty much matches the width of the nose, then you know you're roughly in the right ballpark as far as width of teeth. So the distance between the tips of the canines corresponds to the width of the nose. When looking at the patient from front on, though, you've got to remember we set these teeth on the curvature of the arch, to conform to the curvature of the arch. So when you look front on to the patient, the tips of those canines fall in the width of the nose, then you pretty much selected the right size tooth. Okay, so that's size, that's shape, and also shade. Let's talk about anterior teeth arrangement. When setting anterior teeth, there are some guidelines that we can use, and in fact there's some soft tissue guidelines that we can use in relationship to canine position and the size of the papilla. Let's look at the size of the papilla first. But when we look at dentate people, let's have to do a dentate first on the right hand side. When we measure the distance between the middle incisor papilla to the labial surface of the central incisors, there's a range that a lot of our patients fall in. They fall in around 8 to 10 millimeters. So we can use this as a guide in setting denture teeth too. We can use the incisor papilla as a guide in setting denture teeth to set the labial surface of 8 and 9, around 8 to 10 millimeters, facial to the middle incisor papilla. There's another interesting guideline, and it's got to do with the canines. In young people, when you connect a line with the tips of the canines, this usually traverses the middle of the incisor papilla, as in the schematic. In older people, that line is usually posterior, falls posterior to the papilla. And also, when we measure the distance between the labial surface, as you can see on the right-hand side, to dentate person, to cast the dentate person, when we measure the distance between the labial surface of the canine to the lateral aspect of the anterior rugate, it tends to be an average of around 10.5 millimeters. So we can use these as guides in our complete denture setups with our dentureless patient as well. Phonetics is very useful. Phonetics helps us work out and fine-tune position of teeth. Essentially, when you say an F word, a fricative, the incisor edges of your maxillary teeth touch the wet-dry line of your lower lip, which is your vermilion border. So when you say F, B, the incisor edges of your maxillary teeth just lightly touch that vermilion border. And it's got to touch the vermilion border just lightly in order for it to sound right. If the teeth are placed too far posterior, which means the teeth are placed too close to the size of the papilla, they're not going to be able to sound the F word right. Same thing, if they're placed too far forward, they're not going to be able to get contact with the lower lip and sound those fricatives. Syllables are very useful too when you're doing a wax control denture appointment and you're evaluating speech and you're evaluating tooth position. Now the vertical position of those anterior teeth can also be evaluated during syllables when you say an S word. For example, when the S word is sounded correctly, what's happening is this. When we say S, we bring our lower anterior teeth forward and we bring them to the same vertical position as the same horizontal position as the maxillary central incisors. So we bring them edge to edge, incisor edge to edge, but they don't touch. There's a little gap, and that little gap is called a closest speaking space. And that's how you say an S. So when you say S, its lower anterior incisors come close to touching the maxillary anterior incisor edge as well. If when trying to say an S, the patient is unable to bring those lower anterior teeth up to the incisor edges of the maxillary teeth, like this in the image on the right, they tend to whistle. So it's inadequate, they're unable to do that. And so what the problem is here is that the patient has way too much overjet. Way too much overbite. There's too much of an overlap between the teeth. The patient's unable to get that lower teeth forward. And then, if you have excessive space between those lower anterior teeth and the upper anterior teeth when trying to say S, the patient tends to lisp, which means we have to reposition those teeth, either bring those maxillary anterior teeth down bring those mandibular anterior teeth up. In other words, what we do have to increase the amount of overjet. So if we've got too much overjet, they might whistle. If we don't have enough, they might lisp. And these are just guidelines that are very, very useful. So kinetics are very useful. So again, a horizontal relation, we want those anterior incisors to come pretty much level with each other. If they're too far lingual, it's going to be excessive. If they're too far forward, like a class 3 relationship setup, or the maxillary anterior teeth are too far lingual, it's going to be deficient. Cool. Let's talk about the maxillary anterior setup, teeth 6 to 7, 6 to 11. It begins here. It begins at the maxillomandibular jaw relations appointment. All of it begins here with adjusted wax occlusion base rims. So I'm going to go now and digress and segue into this section of the denture sequence, which is the maxillomandibular jaw relations appointment. Now essentially, when we look at averages in dentate people, these are the averages we find. We find that the average distance between the incisor wedge of maxillary anterior tooth and the mucobuccal fold, which is where the phalangeal denture sits, is around 22 millimeters. And in the mandible, distance from the incisor wedge to the mucobuccal fold is around 80 millimeters. And it averages around 15 to 80 millimeters posteriorly. So this is where we start with the wax occlusion rims, and then we adjust those in the mouth and take an intraocclusal record. The maxillary occlusal wax rim is adjusted before we adjust the mandibular rim. And these are some of the guidelines that we use when adjusting that maxillary occlusal wax rim. The Camper's line, which needs to be parallel to the occlusal plane, and the interpupillary line, which needs to be parallel to the anterior portion of the wax rim. So let's go over both of these in greater detail. So this is what I start with first. I always start off with adjusting the anterior maxillary interpupillary line. I always adjust the anterior part of the wax rim before I go ahead and adjust the rest of it. Basically, as we look at this patient here, this is Bonnie, what we're looking to do here is adjust the wax rims so that from 6 through to 11, it's parallel to the interpupillary line. It's very, very important so we can set up the anterior teeth without a canter, without a sloping one way or the other. Now, how much tooth display should we do? And when we look at literature, what's the appropriate amount of tooth display? Well, basically in complete dentures, as we get older, we tend to display less amount of teeth. So anywhere from 0 to 2 millimeters of tooth display when the lips are at rest is an appropriate amount of tooth display. Also, when we look at the literature and we look at what is pleasing to the layperson, generally, when there's more than 4 millimeters of tooth display, that is with the lips at rest, which means repose, which means rest, the layperson considers more than 4 millimeters to be considered anesthetic. So as long as we stay within that 0 to 4 millimeter range, as far as the amount of tooth display at rest, this is at rest, not when it's smiling, at rest, we're going. 0 to 2 is probably a good guideline as far as that. And you can see Bonnie, I've got about 2 millimeters of tooth display when Bonnie is resting. Of course, we can't adjust the anterior without adjusting the posterior wax. We've got to adjust both at the same time. And for maxillomandibular relations, it's really about getting a rough occlusal plane. It's not about getting a definitive occlusal plane. The definitive occlusal plane is going to be determined during your posterior setup and the relationship of the lower anterior teeth to the patient's retromolar pads. So the occlusal plane is really going to be dictated by the posterior teeth and the anterior setup. But we need to give the patient a rough occlusal plane so that we can establish a vertical dimension and take an intraocclusal horizontal record. And this is a great occlusal plane, rough occlusal plane. It's called Camper's line. Essentially, Camper's line is a line drawn from the superior border of the tragus of the ear, and this is the tragus of the ear, so this triangular bit right here, the superior border of the tragus of the ear, to the inferior border of the ala of the nose. And this little round section of the nose here is the ala of the nose, so the inferior section here. And adjusting the posterior portion of the wax rim to be parallel to the Camper's line. So when I'm adjusting the anterior portion, I'm also adjusting the posterior portion. I'm using a hot wax knife a hot wax plate to do this, like a plaster putty plate that you can buy from hardware stores, things of that nature. Adjust it, put it back in the patient's mouth, and then with a fox plane, this instrument over here, shown in the previous slide, and then with a fox plane, check that out and check that those parameters are working. Midline, very, very important to put a midline in there, and what I use is floss. Get a long strand of floss, stand in front of the patient, patient's upright in the chair, the patient look at me, I close one eye, and I try to average the patient's face with floss. Everyone's got asymmetry in their face, and so I try to average out the asymmetry, and then visualize where that's going to be on the wax rim, mark the wax rim, and check it again. Usually the midline corresponds to the frenum of the patient's maxilla, so that's another rough guideline you can use. But it's important to use the floss technique, look directly at the patient, and mark the midline of the wax rim. Okay, so there's some basics. Occlusal vertical dimension. Well, we can't adjust the mandibular denture without an understanding of occlusal vertical dimension. And what's the appropriate occlusal vertical dimension for the patient? Well, essentially, occlusal vertical dimension is the rest vertical dimension that the patient has that day minus intraocclusal distance. The average intraocclusal distance for a person is around 2 to 4 millimeters. And this is what I do. I put a couple of marks on the patient's face. I just get a pen. I mark the apex of the nose with a pen, the apex of the chin with a pen. I have the patient sit upright and relax the jaw. So here's Bonnie in a relaxed state. Have the patient rest their jaws, have lips slightly touching, and have the patient breathe through her nose. And then I measure this distance, and this distance I'm trying to get is this rest vertical dimension. So let's say for today's appointment, the distance between that dot and that dot is 70 millimeters. If we deduct 3 millimeters being the intraocclusal distance, we end up with a dimension of 67. So for that day, for that appointment, Bonnie's occlusal vertical dimension is going to be 67 millimeters. Every time Bonnie comes in and we do this, we have to put new marks on her face. So these numbers might be 69, 71, 72, depending on where I place the mark on her face. So just for that day, it's 67. If these marks get lost, we have to start this process all over again. So that's how we determine the occlusal vertical dimension. Then the mandibular wax rim is adjusted to fit flush with the maxillary rim at that occlusal dimension at 67, measuring between those two dots. Horizontal jaw relationships, that's the next step. Well, in complete denture therapy, what are we talking about? We're talking about centric relation. It's really quite interesting when you look at the glossary of proselyte terms, and you can Google this, you can Google the glossary of proselyte terms. It's interesting, there are so many definitions for centric relation. It's quite incredible. Pretty much all say the same thing, with nuances. But for complete dentures, this is probably the best description for centric relation in relationship to your edentulous patient. Centric relation is the most posterior relation of the lower jaw in relationship with the upper jaw, but in which the patient can make lateral movements of the jaw at a given vertical dimension, which is the vertical dimension of occlusion for that patient. And this is a really good definition. So it's a retruder. It's essentially a guided position though. It's a retruder posterior border position, and in healthy people, it's considered to be constant for clinical purposes. So essentially centric occlusion needs to match centric relation for the patient. So when the patient bites together, centric occlusion is equal to centric relation. It's the only repeatable position that we have for completely edentulous patients. They have no teeth left to guide them. So after these wax rims are adjusted, we place these little keyways in the wax rim to engage an intraocclusal record. We do this in the same as well, posing keyways in the maxillary rim. And then you take an intraocclusal record. I'm going to discuss with you a couple of techniques in taking a maxillomandibular intraocclusal record, which is a horizontal CR record. What I do is I place my fingers on the mandibular buccal flanges and I hold the space stable to the mandibular arch, mandibular jaw, and I put my thumbs underneath the chin just to stabilise this mandibular wax rim. And I'll practice with the patient basically. I have the patient, instruct the patient slowly closing the back teeth. But I do one more little thing. I practice with them. I have the patient curl the tip of their tongue and have them point to the roof of their mouth, but the posterior portion of the mouth, not the anterior. I'll practice this with them. I have a patient, I tell them to open their mouth just halfway, curl your tongue back, touch the roof of your mouth with the back of your mouth, and gently keep pointing towards the roof of your mouth while you slowly close. Practice this a few times, and then place the interocclusal record and give it a go. I'm using a soft polyvinyl siloxane material here. Now the patient closed, and then I haven't stopped just before the wax rims touch. There's a reason for that. If I can have them stop just before the wax rims touch, like half a millimetre to a millimetre gap, it prevents the patient from sliding around and giving you an aberrant recording. When wax rims touch, often they might slide left, right, and end up incorporating the slide in a record. So that's why I have them keep the mouth slightly open in this way. And then you can accommodate this within the anterior sizal pin on your articulator. You can accommodate the space when articulating the cast. After that, you repeat it, you check it, and after the sets, you just check that record, trim it and check it, make sure it's correct. If it's not correct, do it again. It doesn't take very long at all. That's essentially the technique that I use. And then you mount it. You mount these on an articulator. You take a base bow record and mount it on an articulator. Base bow record is it important? Of course it's important. It enables you to position the maxillary arch in a rough position in relationship to the patient's condyles. And it helps you when doing occlusal setup and doing jaw relations. There are two types of base bows, kinematic and arbitrary. Kinematic is a super accurate one. It's used to locate the true terminal hinge axis. And it's a little bit overkill in complete dentures. In complete dentures, an arbitrary face bow and a semi-adjustable articulator is usually what's recommended. And now the arbitrary one just takes, it's based on average computations of the axis of opening of the jaw. So really this arbitrary face bow is what I'm going to recommend, as well as a semi-adjustable articulator. So that goes over that area. I'm going to go now into anterior teeth setup, and I'm going to finish this next few slides and give some time for answering questions as well. Well, there are some more guidelines that I can share with you about setting teeth from canine to canine maxillary arch. And I'm going to share this mnemonic with you, MIG. This mnemonic relates to the buccolingual position, the buccolingual inclination of the maxillary anterior teeth, when viewed from the occlusal, when viewed from the incisal edge. If you're looking from the occlusal aspect of the tooth, looking down on that tooth, and you're looking perpendicular to the occlusal plane, this is what you tend to see. You tend to see, ideally you want to see this area here. You want to see the middle to be more prominent when looking down the occlusal aspect. And for lateral incisor, you see the incisal edge is more prominent when looking down. And from the canine, the gingival aspect is more common. So let's look at this MIG mnemonic. So essentially, it's a pretty dominant positioning for the central incisor. Just a very, very slight canter. The neck is brought in slightly so that the middle half is predominant. With a slight distal canter too. If you notice the long axis is tilted distally slightly back in the neck. And this is what it looks like on body setup. Let's go to the lateral incisor. The lateral incisor, a couple of things you'll notice first. The neck is distalized slightly even further than the central incisor. And it's also the neck is brought in more towards the lingual than the central incisor. By pushing the neck in more towards the lingual, when you're looking down the occlusal plane, perpendicular to the occlusal plane, the incisal edge becomes more predominant. You see the incisal edge. You're going to see this the rest of the tooth. Hence I. So the incisal third is more predominant when looking down the occlusal plane for lateral incisor. Let's go to Bonnie again. And you can see there's more of a distal canter. And also one thing you'll notice in my schematic that I've drawn here, I often position the incisal edge about 0.5 millimeter to 1 millimeter above the incisal plane. It gives a more realistic, more natural looking setup. If you put this tooth on the incisal plane, it doesn't look natural, gives the appearance of wear and age, where the patient is flattening their teeth down. It just doesn't look right, and then what happens is you end up with these irregularities right here, too much gum display often in that area. So put in that lateral incisor 0.5 millimeter to 1 millimeter above the occlusal plane is a good idea. Let's go to canine. Canine. pretty straight up and down setup. By setting it up straight up and down without any lingual facial inclination, what you end up is a more prominent gingival third. So if you're looking down in the occlusal plane, from the incisal edge down, you notice the gingival part, hence G in the mnemonic. It's an MIG. Gingival third is more prominent canine. And you can distalize the neck further if you like too. So it starts off pretty straight, a little bit more. The neck distalized, distalize a bit further with the canine. A couple of things about canine position, either place it on the plane or place it a little bit higher up. A little bit higher up. And this is a wax arm. And then you take this patient's mouth and you fine-tune the position of the premolars. One very important thing, in complete denture occlusion, in order to set the lower anterior teeth, that's what's next, is we set the lower anterior teeth in relationship to the incisal guidance angle. What is that? Well, essentially, the incisal guidance angle is a line, an angle drawing a line between the incisal edges of the maxillary central incisor to the lower central incisor, and in relationship to the occlusal plane, the horizontal plane. That is incisal guidance angle. This angle needs to be the same as the angle of the cusps of your posterior teeth. So, depending on what type of occlusion, posterior occlusion you do, whether it be lingualized occlusion or whether it be backalized occlusion, is the cusp angle of your most steepest posterior denture tooth, whether that be 22 degrees, 33 degrees, whether it be 10 degrees, that's what you set your incisal guidance to. That's what you set your incisal guide pin table to. Essentially, you provide the patient an open anterior bite. And this is to provide stability during function. If you close the incisal guidance so that the teeth are actually in contact, like in a dentate patient, you develop instability in the occlusion. So that's why we have a gap here. So the patient ends up with an open contact. But by maintaining this angle identical to the cusp angle, posterior cusp angle, when a patient moves into a protrusive or lateral guidance, it will enable the patient for those incisal edges to actually come into contact. We call this kissing contact. So protrusive and lateral worker movements will produce a kissing contact. So they can incise and bite into the sandwich and bite into the contents of the sandwich. But this is biting setup. So you see she has an anterior open bite. And that's normal for complete denture occlusion. Now this module is not about complete denture occlusion, but I did want to allude to this. There's also a mnemonic for mandibular incisor, IMG. So when looking from above, and we're looking from above and we're looking down, perpendicular to the occlusal plane, I, that means the central incisor, the incisal third is more prominent, M, the middle third, the lateral incisor is more prominent, and G, the gingival third is more prominent. When we look at these teeth in relationship to the facial area, the facial inclination, central incisor straight up and down, and the neck of the lateral incisor distalized a little, and the canine distalized further. But the incisal edges are placed in relationship to the incisal guidance angle for that patient. So this is Bonnie's setup, utilizing her raised mandibular teeth. Another thing, we want to align the teeth so that it follows the curvature of the arch. So the incisal alignment is regular and follows the curvature of the arch for the patient as well. This is critical too. And then we try it in the patient's mouth, and this is Bonnie. And what I did in Bonnie, I fine-tuned a few things. I often moved premolars and canines. Canine, the first premolar around, and in her situation, I lifted her canine up a little bit on that side, just to follow the curvature of the lip. I brought that premolar around as well, and give a pleasing smile. Just fine-tuning some of these teeth before processing, and then having Bonnie accept it before doing so. And then we can take it to a finish. And this is Bonnie's finish. And it looks great. It looks really good on her. And just utilizing all of these principles that I shared with you. And I'm going to go back a slide, but when we had this wax trial appointment with Bonnie, I went over phonetics, I went over not just aesthetics, I went over phonetics, made her say syllables, made her say fricatives, get an idea of how she's able to wrap her tongue around these teeth and make sure that the vertical position is correct. Vertical dimension was correct. I checked vertical dimension again, the same technique as I showed you during maxillary jaw relation appointment. And also check the horizontal record. And what I often do is I take another centric occlusion record, which is centric relation record, Rearticulate the mandibular cast or the maxillary cast, usually the mandibular one I rearticulate. Fine-tune teeth before processing. And by doing that, by taking taking another horizontal record here at this appointment, the advantage is that there'll be less post-operative, there'll be less adjustment when the dentures are finished. And these are the finished results for bonding, applying those principles in these mandibular teeth in place. Wow, I did that super fast, maybe a little bit too fast. I want to thank the sponsors. I want to thank Arrayas. You probably noticed in the presentation that I utilised a lot of Arrayas teeth. There's a reason why. There's many different reasons why. These teeth are quite incredible. The high quality manufacturing, the aesthetics are incredible. And then my number one teeth. Now I use other teeth, of course. I use different manufacturers, depending, because not all teeth fit patients in my practice, but these teeth fit many of my patients as far as size and shape, things of that nature. I also want to thank Knowledge Factory. Now, Knowledge Factory is a company that provides educational resources for dentists. And with the Knowledge Factory, I want to introduce to you all the Complete Denture Residency Program. Over the next 2 to 3 months, the Knowledge Factory is going to be posting many different educational possibilities for dentists, especially in complete denture therapy, from downloadable modules to residency hands-on programs. And if you visit the knowledgefactoryco.com site, you'll learn more about it. But again, a couple months to be more information. And on the knowledgefactoryco.com, there's information about a complete denture residency program that I'm putting on with a local laboratory here in Denver, Colorado. It's a 2.5-day program. And if you want to learn more about complete dentures, the A to Z, you're more than welcome to peruse the site and see if it's a program that's going to work for you. I'm going to engage the audience now. I've got a bunch of questions here to look at, and you're more than welcome to email me at aldo@aldoviaparty.com or visit the knowledgefactoryco.com website. So what I'm going to do right now is just have a look at some questions. Choose some questions here. Trying to find a question here that I can start off with. Here we go. Next. Okay, I'm going through questions. I've answered all the questions in the presentation. A lot of these questions were written as I was presenting. Okay, here's a question. What metal instrument am I using intraorally to check the occlusal plane, and especially in relationship with campus line? The instrument I use is called a Fox plane, and you can purchase these from your dental supplier. So FOX plane. It's got a couple of lateral wings and an anterior portion. It also has a rim for the patient to put some pressure on, so that you can, against the wax rim. So it's called the Fox plane. So thank you for that question. Let's have a look. I've got a question here. Would the S, the syllabus and the frictive sounds, will it be the same if the patient had a class 3 occlusion and in CR? And that's a very good question. The class 3 occlusion patient is probably one of our most challenging patients to deal with for a number of reasons. And what we need to do in a class 3 patient is fudge it a little bit. We may have to bring those maxillary anterior teeth a little more forward, and bring those mandibular anterior teeth a little further back in relationship to where the alveolar processes are. And we do this for a couple of reasons. We do this for aesthetics. We do this for function, to get rid of a reverse overbite. We also do this for phonetics, so that when a patient says an S, they're able to bring those lower anterior teeth up against, like incisal edge to incisal edge, up against the maxillary anterior teeth. So what I do in a class 3, as I do in a class 2 actually, I compensate with the position of the maxillary anterior teeth, maybe lingualize the positions a little bit. Bring those maxillary anterior teeth a little bit more facial and lingualize those mandibular anterior teeth to reduce that class 3 discrepancy in the anterior relationship. For class 2, what I might do there is bring those maxillary anterior teeth a little bit lingual because of the prognathic maxilla, and bring those mandibular anterior teeth just a fraction bit facial because of the retrognathic mandible, in order to enable the patient to be able to bring those lower anterior teeth right up against those maxillary anterior teeth in the same S. Now, for fricative, it's really about the vertical position of those maxillary anterior teeth. If the vertical position is not accurate, it's too shallow, they're not going to be able to get the lip up against those teeth. If it's too long, it's too verticalized, then they're going to hit that lower lip really hard when they try to say F, and they're going to stumble as well. So that's the fricatives. I'm going to continue. Okay, let's go over here. Right. Let's see some of these questions. Where's the final denture? Okay, there's a question here that says, how long does the patient use the temporal prosthesis before placing the final denture? I'm not sure what this question is in relationship to. I would imagine it could be in relationship to implant therapy. If it's a complete denture patient and we're just sticking to complete dentures for their treatment plan, the patient's going to have usually existing complete dentures, and these complete dentures, what I would do with these complete dentures is essentially reline those complete dentures if needed with a tissue conditioner reline, adjust the vertical dimension of the existing complete dentures, and that'll be the temporary ones, while we're making and fabricating the definitive ones. If it's an immediate denture, that means that these patients have been, the teeth have been removed, and they have the first denture, the immediate denture. The immediate denture therapy in my office goes from 9 to 12 months. That's phase 1. So phase 1 is the first set of denture. And while the patient is healing, I'm continually relining the intaglio surfaces of the dentures with a tissue conditioning reline material. Now, these different tissue conditioning reline materials during different phases of therapy. I use a short term in the first 3 months, and then a longer term temporary reline material from the 3-month to 9-month period. And then at the 9-month period, I evaluate the integrity of those immediate dentures. And if they're in good shape, we do a laboratory reline, a hard reline around the 12-month period. And then those dentures are good for another 2 to 3 years before the residual alveolar ridges change and they resolve. And the patients are fully aware of this. It's in a treatment plan for maintenance that, unfortunately, one of the sequelae of complete denture therapy is continual residual ridge resorption. So the intaglio surface is not going to adapt so well after a 2 to 3 year period. I tend to find that 2 to 3 years is a great number as far as relining the mandibular denture, and for the maxillary arch, anywhere from 3 to 5 years. And the reason for that is patients do quite well in the maxillary arch because of the suction effect, the fact that the palate is covered, it's a posterior palatal seal, and the flanges provide this little suction effect. So, so that's how long we use these prostheses, either as a temporary or use these prostheses as far as relining them definitively. I'm going to answer some more questions. Let's have a look. One question is, am I a prosthodontist? Yes, I'm a prosthodontist. I'm practicing in Denver, Colorado. Here's another question. Let's have a look. Question. At the centric relation record, the space that is in the anterior that I showed earlier, you notice when I did a centric relation record, there's a bit of a space about 1 millimeter. Is the vertical dimensional occlusion altered? That's a very good question. When doing a centric relation record, if there is a gap, there's a gap between the teeth like I recommend when you do your record, yes, you're increasing the vertical dimension. What you have to do, though, is close that pin back to the vertical dimension that you chose. When adjusting the wax rims, you adjust the wax rims so that they're flush with each other. They actually are in contact, even contact with each other at the correct occlusal vertical dimension, at the vertical dimension of occlusion that you've determined for that day. So what happens is when you articulate the case, you remove the intraocclusal record, you loosen the incisal guide pin on your articulator, and you have those wax rims come into contact. Close the incisal guide pin, that is your vertical dimension you're working from. It's the same vertical dimension that you adjusted those wax rims to in the patient's mouth. And the only difference is that incisal guide pin may be at a negative number instead of at a 0. Sometimes, if you think ahead of time, which sometimes I do, sometimes I don't, you can measure the thickness of your intraocclusal record. It might be 0.5 millimeter thick, 1 millimeter thick, and you raise the incisal pin by 0.5 millimeter or 1 millimeter, so that when you release that incisal pin and you have the wax rim come back into contact, it tends to zero out on the articulator. But yes, it's going to start off with an open, slightly open vertical, but you close that vertical back to the wax rims coming into contact on your articulator, record that number on the incisal pin, and that's what you work from. That was a very good question. Actually, all these questions are quite good. Question, do I ever use a Gothic arch tracing for centric? Gothic arch tracing is another wonderful way of taking a centric occlusal record, and I have used it before in the past. I tend to find it's a little overkill, and utilising the techniques that I shared with you also work very well. It's really about the patient being able to reproduce that hinge record, the centric relation record, and at the correct vertical dimension of occlusion. That's what you need to achieve, and you can achieve that with the techniques that I showed you. But if you're comfortable with the Gothic arch tracing technique, excellent. It's fantastic, and I also recommend that. Another good question. Some really good questions, guys, and I appreciate it. I've got a few minutes left, and I'm going to answer the rest of these questions. What else can be used to stabilise the maxillary and the mandibular occlusion rims during your jaw relations appointment? That's a really good question. This module doesn't discuss how these wax occlusion rims are made, that they're quite accurate. But if you find that your wax occlusion rims fits like socks on a rooster and moves around too much, obviously you're going to need to adjust them. Maybe the flanges are slightly overextended, maybe the depression is slightly overextended. You adjust those. But you can use denture adhesive. Probably denture powder. I like to use denture adhesive powder. Various manufacturers make powder, they make gels, and use that when actually doing a record. And don't use a lot, just use a little bit, enough to stabilise the wax acrylic rims, enough to stabilise those. You don't need to use a whole lot when doing that. So that's one technique. Another technique which works really well is after you've taken secondary impressions and you pour a master cast, you do a posterior palatal seal, scribing on the master cast. What you can do is you can actually have the lab fabricate definitive bases on those master casts. So the lab will duplicate the master cast and fabricate definitive bases. And you can set with wax the teeth on the definitive bases. Put wax on that for your maxillomandibular records and then put teeth on. And then the final denture is processed onto that definitive base. And that's another technique. And obviously, your definitive base is going to fit really well. And if it doesn't, you can adjust it accordingly, like you would adjust your regular denture, and have it fit. So that's another technique. Either you have very accurate wax occlusion rims, which is the technique that I use, but I've used both, or you have a lab make you a definitive base that's about 3 millimeters thick all the way around with a flange, and you use that as for your jaw relations, or your trial denture setup, and the lab will process to that definitive base. I've got a question here regarding a dentist doing a setup versus a technician. The reality is, in clinical practice, the technician is going to be doing most of your setups. But it's important that the dentist understands the parameters. The technician often doesn't understand these parameters, so the dentist needs to communicate effectively with the technician. How do you want your teeth to be set up? And then during the wax trial denture setup, it's important that the dentist has the confidence to get a wax knife out and move the tooth around, try it in the patient's mouth. Keep moving the teeth. Well, I'm getting close to the end, guys, and actually I am at the end. For those questions that I haven't answered, I apologise. I want to thank you for your attention. I hope this has been helpful. Some of the pointers that you can take to your practice. If you've got any questions, you're more than welcome to email me. Again, thank you, Ray, at Knowledge Factory, and have a very good night. Thank you.